All right. So again, thank everyone for being here. It's a joy to be with you all and to get the opportunity again to work with Mr. Montgomery. And so I have been given the distinct privilege tonight to introduce Dr. Kevin Sneed. And it is indeed a pleasure and actually a very difficult thing to do because you can read the kinds of things, people's education, you know, the kinds of things that they've done, and just hope that what you share really gets at some modicum of who that person really is. And I don't think in this case it does, but I'm going to do it anyway. And I also want to say that this is a very, very abbreviated version of an introduction for Dr. Sneed, because if I read his total bio, it would take so much time that all of us would just want to sign out and go home. So I'm just going to say that Dr. Kevin B. Sneed is a tenured professor and the founding dean of the University of South Florida Tanager College of Pharmacy. He also serves as a senior associate vice president for USF Health. Dr. Sneed earned his Bachelor of Science degree in biology with a concentration in microbiology from the University of Central Florida. He received his Doctor of Pharmacy from Xavier University of Louisiana College of Pharmacy. He completed an ambulatory care pharmacy practice specialty residency at Bay Pines Veterans Administration Medical Center. He has received numerous clinical and leadership awards, and I won't go into that very extensive list. He also, as we know him right now, the executive director of We Care, a community-based participatory research entity that strives to bridge the gap of health disparities by educating diverse communities about the process and the importance of research participation. Dr. Sneed also serves on the board of several organizations and participates in many community endeavors. So as far as COVID is concerned, Dr. Sneed is served on the administrative team for the university COVID effort and investigator for one of the COVID vaccine trials. And as many of us know, has really provided all together during this period with Dr. Sneed, Dr. Hill. We think over 200 workshops that are related to the symptoms, treatment, impact, and the use of vaccines to end the current pandemic to diverse community, civic and social, Greek business, faith-based groups through virtual workshops, radio and television interviews, Facebook Live, and other platforms. And most recently, we actually had an in-person session at the C. Blythe Andrews Library on Martin Luther King, and that was indeed a great joy. So I'm just going to turn it over to Dr. Sneed now. With all of the things that we said about him, we are truly, truly blessed to have him in our community. And I feel especially blessed because whenever he calls me and I pick up the phone, he says, "Hello, my friend." And that to me is one of the most important and special things that could ever happen to me. So I would just introduce to you and present to you Dr. Kevin B. Sneed.
Dr. Sneed and Dr. Austin, you both are on mute.
Oh, I just muted myself. Yeah. There we go.
Yeah. Can you hear me now? Yeah. Well, I was what I was saying. It was really important what I said. I don't know if I can say it as clearly as I was saying it like 10 seconds ago. I just wanted to say, Dr. Austin, for all my friends here with Phi Beta Sigma, their guests, throughout the pandemic, as you look back, the reflection of the relationships you build are just as important as having endured getting through the pandemic. And for any kind thing that Dr. Austin said about me, number one, there's a multiplier effect. You can say that, and it applies doubly to Dr. Hill. my great colleague. Everything she said about me applies to her, in many cases more so. And then you take Dr. Hill and myself together, and then we probably still really don't match up to the impact that Dr. Austin has had on the community, on this community here in Tampa. And I'm just being sincere. If it weren't true, if it weren't in my heart, I just wouldn't say it. But this evening, we're gonna get started. Oh, did we acknowledge Dr. Pastor Hiram Green? Yeah, so the fourth member of our team. I think many of you know Hiram Green. We've given him so many titles during the pandemic. He's got a wall full of diplomas and titles. I mean, he's wearing the clergy cloth. Mr. Pastor Hiram Green, I want to thank you for being here. This evening, what I'm going to do, I'm going to go pretty quickly because I'm going to turn it over to Dr. Hill in tandem. There's information. What we're trying to do now, Mr. Montgomery, as a We Care entity in collaboration with Reach Up, what we want to do now, we want to we're not wrapping up. The pandemic is not over. Please hear me. You know, I'm only going to talk to you all for about 15, maybe 20 minutes maximum. And I'm going to turn it over to Dr. Hill, but the pandemic is not over. So please get your questions ready. But what we're trying to do now, we want to keep these conversations going because I am assured in my scientific mind and the scientists I am communicating with all over the world now. And I do literally mean we are communicating around the world. I've got a person in South Africa that I'm communicating with and very effectively. We're convinced that there's a great potential for another more dangerous variant to come later this year or sometime early next year. And I can explain that comment to you all when we get to a Q&A. But I'm going to share my screen here and give you all a little bit of background information. And then hopefully when we get to a point that we really need people to better understand and appreciate a lot more of the virus, that people will be much more understanding of what this thing really is. So let me share my screen here. Okay, and we're going to go ahead and get started. So right here, I just put this in. I found this on this animation a couple of months ago, and I don't know if I'm putting it in for you all or more for me, but this is my illustration to kind of let all of you know that yes, indeed, COVID, the virus that causes COVID-19 is real. Now, what you're looking at here are when people are talking about variants. And before I go any further, let me just say what I'm going to attempt to do. I'm going to try and pull all of you into my scientific world, but make it understandable. And so what you're looking at here, what we're looking at here are the different variants when that came up. And we keep hearing about the variants and we want to know what's different about the variant. Well, as I describe it to people, all the numbers on here, it's like a zip code on the spike protein. And I know it's a little bit difficult to see, but each little spike is made up of 3 different components that kind of make it up, almost like you took 3 pieces of broccoli and kind of pushed and mashed them together. And what has really occurred is that on the far right, the Omicron variant had so many more mutations, and every little number you see on here is representative of a mutation that has occurred with the variant. Now, when the Delta variant came out, we said, you know, it had more dangerous mutations than anything we had ever encountered. And then Omicron came along and we found that it had 50 mutations. And so every time you see a mutation pop up, we have to be cognizant of the fact that it has learned the human body a little bit more than it did months earlier. And so, that's a little what you're looking at here in terms of what all these numbers are. We can identify where the mutations have occurred and we number them. And then we come back and we let people, we let all the scientists know what that mutation likely will do in the body. Now, again, over here on the far right, there's a number, and it's all the way on the far right, and it says INS. That means insertion, okay, INS 214 EPE. So when you were hearing that the Omicron variant was a little bit less dangerous and it was a little bit more transmissible, well, all of that was really because we think that little piece of genetic material that got inserted actually made it take on more of a cold-like type of characteristic. And so it's much more transmissible, and it's the most transmissible form of anything that we've encountered so far. Now, the other thing I really want to help people understand is that over time, these different variants have occurred. We've been able to identify where they come from. And we are pretty much kind of understanding now where the next variant may come from. We have an understanding of where it may come and why it may occur. But the one thing that has really bothered all of us about the Omicron variant is the fact that it came from such a long time ago, way back, has its origins way back in 2020. Almost all of the dangerous variants that we found, Omicron and Delta, they impacted so much of what we did in 2020 and 2021, but the Omicron variant has a genetic lineage, kind of what I call the 23andMe, that extends all the way back to almost the earliest form of all the variants during the pandemic. And so we really are concerned what that may mean for the future. So I want to make sure that we are fully aware of what's happening. So the Delta variant had been the most dominant variant across the United States. And that's what we find here in all of the orange. And then at the beginning of, December, the Omicron variant, it kicked in. And then by the end of December, and then by the end of January, 100% of all the cases out there became the Omicron variant. And then invariably, we started seeing another version of Omicron called BA2 that began to kick in. And so we saw that at the beginning of February. And so here's where we are today. The BA2 variant is the most dominant variant going on across the United States right now. It makes up about 86% of all the cases out there. However, the other two versions of the Omicron variant are still kind of floating around. And the original version of all of that kind of started off everything is at a really low number. So the pandemic is not over, but the case numbers are severely down, and we're very happy about that. And so for all of us here, and again, I understand that I can't see everybody. I do understand that all of us tonight may not fall into a category of being African-American, but I'm going to speak directly to African-American and Latino populations here for a quick moment. The only reason I'm putting this in right now, I want you to look to the far right, and I want you to see that this particular virus, it can only attach onto what we call the ACE2 receptor, ACE, and then the number 2. And when it attaches on there, that's how it gains entry into the cells of your body. Now, all the little spike proteins I just showed you, all those different mutations, means that it has learned how to get into these cells in our body even more and replicate faster than they've ever done before. But the most important thing I want you all to know, and I want you to hear it now, the ACE2 receptor is part of our cardiovascular system. Many of you may be on a medication, lisinopril, a blood pressure medication called lisinopril. Many of you may be on a blood pressure medication called losartan, that's another very popular one, or valsartan. These are all blood pressure cardiovascular medications. Well, they have involvement with a different part of the ACE family, but this particular virus, it attaches on to that ACE2 receptor, and it's part of our cardiovascular system. So I put this in because I really wanted people to understand that in the African American and in the Hispanic or Latino populations, cardiovascular disease is the #1 killer and the #1 cause of death. But for people that have high blood pressure, for people that have diabetes, that means that now we have a revved up cardiovascular system, and that virus is attaching on to the very same receptors that our body is having to try and deal with and manage when it comes to high blood pressure. So anyone that that is susceptible to having a cardiovascular complication is going to be more susceptible to having a problem should you become infected with with the virus that causes COVID-19. Now, I identified this way back at the very beginning of the pandemic, and you can see in the lower right corner. This was an article I wrote back in late May of 2020, not long after the pandemic had started and was spreading like wildfire across the country. And what I was able to identify at that time is why African Americans were dying at such a high rate, at the highest rate early on in the pandemic, because I understood even back then at the very beginning that people that had high blood pressure, diabetes, that may fall into the overweight or obese categories and these different cardiovascular complications, that should they become infected with this particular virus, that it would actually turn on inflammatory proteins, leading to a much higher chance of being hospitalized or potentially even having death. I put this in just very quickly for people who have diabetes, that any area or any organ, your internal organs that can be affected negatively by diabetes can also be negatively impacted by the SARS-CoV-2 virus. So your internal organs from underneath your collarbone all the way down into the pelvis, and even the blood vessels throughout your body can actually, if you become infected with the virus, can actually cause a great deal of problem, a large amount of inflammation, leading potentially to organ damage, and hopefully, or not hopefully, it could lead to death. And again, I show this again just to make sure people understand that all of our internal organs, the most vital organs, all have the ACE2 receptor on it. And therefore, it is more than just a respiratory virus. It can affect the heart. It can affect the kidneys. We had a lot of kidney damage happening at Tampa General Hospital. It can affect the intestinal tract. It can cause blood clots in the arms and the legs. It can even cause blood clots in the brain. And then it can also affect the male reproductive organs. And then again, Dr. Austin and Dr. Hill, they heard me back in the middle of 2021. Again, I found this article and I began to realize that not only would it affect people negatively who might be diabetic, but because the virus can attach onto the pancreas, one day it may actually lead to people developing diabetes. And this was just the beginning article that talked about that. And then sure enough, just earlier this year, we found that for individuals, in this case children, who had been infected and were not vaccinated, actually now are developing a much higher prevalence of diabetes at a higher rate than those children that were not infected. And so we're beginning to pay attention to what are going to be the long-term consequences of being infected by this particular virus. And again, here, we began looking at what's the overall incidence of COVID-19 that may actually cause a lot of the problems that people were encountering. And when you see these separations in these lines, it kind of shows that individuals that had COVID-19 were much more likely to develop these complications with diabetes after being infected with COVID-19. Here we're showing a greater prevalence of hospitalization, especially for individuals that were unvaccinated. If you were not vaccinated during the entire pandemic, but in particular during the period of Delta and then Omicron, you were much more likely to be hospitalized. For people who were actually vaccinated and then boosted, the thick dotted line on the bottom, you can see how much lower prevalence we had of people going into the hospital. And then here, well, it's kind of the same thing. And so I'm going to show a video here very quickly, and then I'm going to turn it over to Dr. Hill here in a second. But here's a video that kind of illustrates a little bit about how, oh, wait a minute, I may, well, we'll see if it, I'm going to do something here because I believe I forgot to click that little button, share sound. There we go. Okay, we're going back. Okay.
Coronavirus. Like many viruses, it uses a protein on its surface to attach to and enter our cells. Antibodies that fit onto this protein can block the virus from attaching. Coronavirus mRNA vaccines teach our immune system to make these antibodies. How do mRNA vaccines do that? mRNA is a genetic material that instructs our cells to produce proteins. The mRNA in the vaccine is wrapped in a layer of fat particles that protect it and help it get taken up by specialized cells of the immune system called dendritic cells. Once inside these cells, the mRNA does not enter the cell's nucleus or interact with DNA, but remains in the cytoplasm with other mRNA molecules, waiting to create the enzymes our body needs. When ribosomes read the vaccine mRNA, pieces of the viral surface protein are made. These pieces are then displayed on the surface of the dendritic cell. The dendritic cell travels to a nearby lymph node, where it presents the surface proteins to other cells of the immune system. Some of these cells, called helper T cells, train B cells how to make antibodies that will fit perfectly onto the surface protein of the virus. Other cells stimulated by the protein pieces, called cytotoxic T cells, can kill virus-infected cells. Now, when the coronavirus tries to infect us, our immune system is ready, immediately recognizing, neutralizing, and destroying it before we ever even have a chance to become sick.
So I know you all, and again, I know we'll get to a Q&A here very soon. I know many people have a question about the booster. Should I get the second booster? I'll be very happy to try and address and answer that for many of you. But really what we're trying to do, we want to make sure that you have those antibodies floating around in your bloodstream long before you come into contact with the virus. And so, again, I know we'll talk about a lot more about that here soon. And I put this slide in very quickly, just simply because there are now oral medications that should you become infected, we can give them to you, and they have been shown to be extremely effective at keeping people out of the hospital. And so I believe with that should be my last slide. Oh, we have reach up. And as I'm about to turn everything over to my number one, Dr. Angela Hill, the Associate Dean for Clinical Affairs in our College of Pharmacy here at USF, a very proud Florida A&M College of Pharmacy graduate, completed a residency with a focus in psychiatry and behavioral sciences. And I can't even think of everything else. She's a full tenure professor with us, but more importantly, she is a well-respected clinician, a well-respected researcher, and will share much information about the behavioral impact of COVID-19, both as a consequence of being infected and as a consequence of living. And so I'm going to show this video very quickly that she narrated. So, well, why do we care? Why we care? Why this program? We want to improve health outcomes.
The collaboration between USF Health's Tanasia College of Pharmacy's We Care program and Reach Up Incorporated aims to bridge the gap between underserved communities and access to care. WeCare's mission is to increase the representation of diverse populations in clinical research. It starts with rebuilding trust between academic and clinical institutions through educating and empowering the community, and then providing research opportunities along with protection and advocacy for the participants.
They want to hear the story from folks who have been through a clinical trial.
You have to share all of that information with everybody.
So take the opportunity to have a better quality of life in our communities. Join us.
And so I'm going to stop sharing. And Dr. Hill, I'm going to turn it over to you, my great friend. Oh, now I get to tell you that you're muted.
Now I'm muted. Well, thank you, Dr. Sneed, for that introduction. And thank you for giving me an opportunity to certainly say that I am enjoying every aspect of my job and my time here at University of South Florida. And although, yes, I am a proud Rattler, it has been a pleasure to walk alongside you and Dr. Austin, as well as Mr. Pastor, Dr. Green, in this journey, not just because of the pandemic, but because it has allowed me to be able to interface with individuals like you all, as well as Mr. Montgomery. And so certainly it's just an honor to have this moment. So we've had a chance to speak to you all, some of you, about the pandemic thus far. And one of the things is that we never imagined that we'd be 2 years in to this, and unfortunately, it's seemingly like we lost that time. And what has happened psychologically is it's really had a lot of impact on everything that's gone on. So even though it seems to be a lull, because as the variants have come out, some of them are more contagious than others, and I think everyone is just kind of in this autopilot mode, and they're forgetting that the pandemic is still around. So I'm grateful to Dr. Sneed that he continues to give us these updates and reminding us of the importance and the need for us to still be getting vaccinated and allowing us to continue to learn about the evolution of the virus. But what we're noticing is that early on in the pandemic, there were a lot of reports of things suggesting an exacerbation of the virus impacting mental health. And so this slide just kind of shows where a lot of the crisis lines, their volume of calls and contacts, tripled and doubled in some cases. And certainly marginalized populations were affected quite a bit. And so as we talked about the impact of the disease or the infection on minorities and other underrepresented groups, we still had to take into consideration that we had a lot of things going on psychosocially that were also compounding what we were seeing. And so again, these kind of statistics have not necessarily gone down since the first year of the pandemic. And unfortunately, what has also happened is that the impact has been also seen in terms of healthcare delivery. So some of the facilities and institutions that were previously serving patients with mental illnesses were repurposed to try to help support some of the issues we were having with COVID infection. So when we were running out of hospital beds and there were shortages on ventilators, they were actually repurposing some of the psych hospitals and using the beds in those hospitals for COVID patients. And unfortunately, that meant those that had existing mental illness sometimes became a disparate group that we had to worry about. And so this caused its own kind of epidemic, so to speak, as well as a crisis in those kind of facilities. And then we did notice there were studies that popped up showing that people who were infected were at a higher risk of developing new or exaggerated or having exaggerated problems with mental illnesses. And this also has been quite concerning. So what I thought I would do is kind of tell you, some of the things that are popping up in terms of what we're seeing. And so Dr. Sneed just mentioned about the long-term effects of the infection. For those that are infected, they're at risk, unfortunately, to still having the loss loss of smell and taste kind of linger for a while. But there are a lot of brain effects, namely COVID fog. And if you've had the opportunity, and if not, you can still listen to me talk about the connections between Alzheimer's disease and COVID-19 infection. But we saw really an uptick in the number of cases of depression, anxiety, post-traumatic stress disorder, and I'll talk a little bit more about it. But Dr. Sneed's already mentioned we have children that unfortunately are developing diabetes at a higher rate, and people who've been infected still having issues with fatigue, and sadly, organ failures. So COVID isn't just this one-time thing. And even if you have it, where you have symptoms or mild symptoms, for a few days, unfortunately, you're at a greater risk for these long-term complications. So what we did know too is that healthcare professionals, which were essential health workers, were impacted tremendously, by the COVID infection. And so this slide just kind of shows what we unfortunately saw was an increase in suicide, but the depression and the anxiety, the deaths even, were just alarming and really concerning. And so we have now reached a point where a lot of essential health workers are reporting, episodes of burnout. And it's because the increased workload, has just really impacted their overall passion for their work. And it's just certainly been quite interesting. And I know just as pharmacists, we were already involved in immunization, but we took it to a whole nother high when you saw immunization being offered in some of our standard retail environments, as well as testing. And so it's that part has, been great in terms of allowing us to do more and contribute in more ways. But unfortunately, we've had a lot of staff turnover, a lot of staff shortages, and that makes the work just that much harder. And part of that was because the infection was still managing to spread, and a lot of healthcare workers were impacted, as well by COVID-19. So there were these unusual, exaggerated spikes in anxiety and depression. So when you look at here, again, this is 2019 compared, 2019 shown in the orange, whereas the kind of reddish orange shows, 2020, a little over a year later, about 2-3 months into the pandemic. And what you saw was almost 3 to 4 times increase in the symptoms of anxiety and depression being reported. And then if we look over at the age groups affected, what we found is that there seemingly was a higher incidence in younger individuals compared to older. And again, as the pandemic continued, the rates, seemed to kind of increase even more. And so there were a lot of surveys and things that the CDC started doing to try to track what was going on. And so around June, they put out a report late June, kind of showing that basically about 30% of people that were responding in the survey were reporting symptoms of anxiety or depression, or they were having increases in substance abuse and substance use, stress increased, and even thoughts of suicide. And so this again has gotten everybody's attention and is equally as concerning. Now, one of the things I have to say in working in this area is that it gets a little complicated because men and women express symptoms of mental illness very differently. And so what we find is that a lot of times men are a little bit more susceptible to externalizing their feelings and emotions, but they also resort to a little bit more tendency to maybe substance use and even abuse. But women are more susceptible to things like depression or generalized anxiety disorders. And most times our hormones get blamed, but a lot of it is we have a tendency to seek out medical treatment a little bit more. So it looks like we have more issues than men. But when we also, again, look just a little closer at depression, what you'll find is that sometimes how we express depression and mood is important. So in that, I'm talking to an audience of predominantly men tonight. What I want you to walk away is noticing, one, some of the symptoms symptoms that could suggest depression. And then pay attention to the women that you're around, and just focus on how long these symptoms may actually occur, because we consider it to be pathologic or something that might, warrant intervention when the symptoms have occurred for about 2 weeks or longer. And we do know that all of us are accustomed to situations of high stress, but we'll bounce back. So that's why we do allow a certain period of time where we have changes maybe in sleep or appetite or irritability and those kind of things. But when it's complicated by ingestion of alcohol or use of illicit substances and things, that just kind of makes it a little bit more challenging. So I do want to make sure that you walk away understanding that we might have some of these issues a little bit more, and it might just look a little different, between the genders. And so in terms of treatment, one of the things that is still an issue is the stigma associated with mental illness. People don't want to talk about it. They want to pretend it doesn't exist. And they also don't want to be put on medication. But there are opportunities for treatment that are non-pharmacological. Most of it is really talk therapy that can really help us develop a lot of coping skills and kind of try to work through situations. But then pharmacological approaches really help correct some of the chemical imbalances that we know are inherently out of place or out of whack in mental illnesses. So just like when individuals get diabetes, there are changes in blood glucose levels. Well, in the brain, it's a factory of neurotransmitters and neurochemicals that actually modulate our mood, as well as other things. And so most times when people have depression or anxiety, there might be just deficiencies or overactivity with some of these neurotransmitters and chemicals. And that's where pharmacological therapy becomes really beneficial. But we can support it with some of the non-pharmacological things that I have here. So again, if you have women in your life and you notice they're a little down, I suggest a massage. A nice massage would be a really good way to perk somebody up. Or I'll take it one step further. Dr. Austin, help me out here, but a spa treatment would be really good. A really good non-pharmacological approach, or what we call alternative therapy. But there's a lot of also high-tech, sophisticated ways that we are treating people for depression, like transcranial magnetic stimulation, vagus nerve stimulation. And some of these things we actually have going on at USF in our psychiatry center. But one that is a low budget, neutral kind of a non-pharmacological approach is simply exercise. And there's studies that show certainly being outside, getting exposed to sunlight, moving definitely just helps us feel better. And so this kind of talks about a study where men who were actually, exercising at least 150 minutes per week showed actual improvements in their overall mood. And so this will definitely, make a difference, and it doesn't cost anything. But exercise is something we should do anyway to minimize developing some of those comorbidities that Dr. Sneed was talking about that have served as risk factors for COVID infection. So in addition to depression, we've had all kind of anxiety. There are a lot of anxiety disorders out there, but COVID has actually shed light on a lot of new ones or exacerbated ones. So when we say anxiety, most times we mean generalized anxiety, but phobias, post-traumatic stress disorder, obsessive compulsive disorder, fear of snakes, fear of heights, what we call phobias, all of those kind of things are examples of anxiety disorders. And we use different medications to kind of help us with this, but this is another example where talk therapy can actually be helpful. But people who have panic attacks, they can have a barrage of symptoms where physiologically we might have reactions like hyperventilating, sweating, racing heart, and or in some cases you might see an exacerbation of certain behaviors. And so what I wanted to point out is that since the pandemic started, there's been this term coined, COVID-19 anxiety syndrome, where a physician in London actually came up with the concept. And what he described it as is a combination or merging not only of anxiety, but some of these symptoms that are associated with post-traumatic stress disorder or obsessive compulsive disorder. And when we think about it, we went first of all, we had to be quarantined, and then we had to go back out into society. And we've had different rates and variations of people being accepting wearing masks or being vaccinated. So you don't really know who's gotten it unless they tell you, and then you have to wonder if you can trust them. And there's certain situations where we may have to show our card, but in most things that we do, like going to the grocery store or going to school, for example, or going to work, we really don't know who has been vaccinated and who hasn't. And this has caused a lot of avoidance behaviors, compulsive tendencies. And yes, as we've encouraged people to use things like hand sanitizer and cleaning agents and all that, it's really ramped up a lot of the paranoia around associated with the pandemic. Even to the point of leading to suicide. So one of the things is that there's a report that goes out typically annually where they actually look at the prevalence of mental disorders. And what has come up is that suicide really has been an issue we've had to think about. Now, suicide is common in people that have mental illnesses, especially individuals who have severe, especially treatment-resistant depression. And then oftentimes it's seen in bipolar patients quite a bit. And we get kind of concerned about that. And when we started out in the pandemic, suicide wasn't as much of a concern as it's become now. And so there are reports that are saying that risk factors, such as what we've experienced in the pandemic, have increased the likelihood of suicide being completed. And so some of the trends we saw, unfortunately, there were increases in domestic violence, increases in sexual batteries, and all kinds of things of that nature that have contributed to, unfortunately, people considering or thinking about suicide. And I did share with you that early on in the pandemic, we saw, an increase in people having thoughts. And unfortunately, we used to think about suicide only being something commonly talked about in certain ethnic groups. It certainly wasn't something you saw or heard about with African Americans. But here we have Chelsea Christ, who was the 2019, excuse me, I think Miss America or Miss Universe, one of those. But, beautiful young lady, looks like she has, the life in the palm of her hand. We had the only son of Regina King, Mr. Ian Alexander Jr., who committed suicide, and they're gone. So we'll never know really the reasons behind. But what we do know is, unfortunately, suicide leaves a deep, big hole in the lives of those people who love them. And so this is concerning. So we look at rates of suicide in men versus women. Typically, women may attempt more, but men usually are a little bit more successful, and the suicidal rate is 4 times that of in men as that of women. And again, as I mentioned, people who are depressed are more likely to at least attempt. So the first couple of months of the pandemic, over 21,000 people reported in a survey that they had thoughts, and some of them had been having thoughts daily. And again, being quarantined, not being able to isolate, a lot of this stuff kind of increased that. Now, the sadder part is that when we look at how stigma is really impacting the decisions people are making in terms of seeking treatment, or even wanting people or others to know that they have a mental illness. When we look at ethnic groups, particularly our Black and Browns, unfortunately, they're not as willing to share as our majority counterparts. And so that part is actually disheartening. And this data is actually pre-COVID, pre-pandemic. But what we saw here is that those that, which are indicated by the lavender-like color, reported thoughts of suicide, those numbers remain very low. Those that reported serious mental illness, those numbers too are low. And then those that reported any mental illness are pretty high. But what you see is, again, a very low number of people actually willing to report that they have or are dealing with issues. Now, some ethnic groups have other non-pharmacological methods that they employ, like religious means, going to church, socializing, being involved in social activities or situations where they can give to others, taking care of others, being caregivers, etc. But unfortunately, what does happen when people don't seek treatment is that they sometimes end up developing a lot of medical issues. And so again, some of the risk factors that are likely to be exaggerated by the pandemic, I've listed on the slide, and I don't want to minimize things like social injustice, the impact on financial security that's come from the unemployment, certainly the hopelessness, the isolation that also went with the quarantining. So individuals who were accustomed to attending church physically, and then if there was any kind of technological illiteracy, or they didn't have access necessarily to the technology to be able to find alternate ways to say, get spiritually fed, that led to a lot of depression, a lot of issues. And certainly husband and wives, as I mentioned, who now had to look at each other much more than they ever had, just realized that in some cases they just honestly didn't like each other. And so we saw a lot of things like domestic violence, as I mentioned, kind of crop up. Hypochondriasis, or again, excessive washing of hands, excessive cleanliness, preoccupation with that. This was something also that we saw spike a lot. And we do have individuals that have had this as a natural disorder, but this was something where people were just so worried about contracting COVID that they literally would wash their hands so much that they would bleed and things like of that nature. And so again, this is related to anxiety, and not to mention the loss that we've all incurred. I'm sure all of us on this virtual meeting tonight can at least say we know at least one person, 5 people, 10 people who unfortunately didn't survive infection or left us for other reasons, due to terminal illnesses or just natural death. But what we are discovering is that people are not able to bring to closure the grieving process as normal, because graveside funerals or virtual funerals or no funeral at all is not necessarily allowing people to grieve in the normal 6 to 12 months that typically take place. And so this has also been concerning. And we've seen a lot of what we call either prolonged grief disorder or complicated grief. And again, women and men may express these symptoms differently. Women tend to talk a little bit more when it comes to grief, whereas men may in fact hold it in a little bit more and try to just keep moving. So I bring this up to say, as men, I'm empowering you, certainly as stewards of your homes, to make sure that you're mindful of women and the people around you, the children, because again, there is a domino effect on this. And a lot of people, think grief and depression are the same thing. They do have common similarities, but oftentimes some people do get in this funk, this mental funk, their ability to maintain relationships and just move on with life after losing individuals, depending on how long or how involved they were in that person's life, is an issue. So in either case, sometimes talk therapy and or even pharmacological therapy, might be necessary to kind of help people pull out of it. And then we can talk all day about continuous traumatic stress disorder. As Black and Brown populations have endured so much, we can relate to what we now refer to CTSD, and it's defined as a state where people are continuously exposed to trauma, different kinds of trauma. And this term was coined by an African who was actually doing studies on apartheid and paying attention to how it affected children. But we just know that some of our marginalized populations have dealt with challenges psychosocially, having alcoholic parents, to constant exposure to violence, again, things like social injustice and, impoverished lives in general have fed CTSD a great deal. And so again, a need for talk therapy. So if nothing else, what I want you all to understand is that there are, again, issues where some people would rather call it post-traumatic stress disorder, but they're actually two distinct disorders. And so the trauma that people are experiencing a repetitive trauma makes continuous stress disorder or traumatic stress disorder something that we need to pay attention to. And what you may see is that people end up, depending on what they're exposed to, particularly in their childhood, they may grow up and have some of these disorders like learning disabilities and panic attacks and some of the other anxiety disorders I've talked about, just as spin-offs and residual from not totally healing and recovering from some of these experiences. And all the more reason why the talk therapy might actually be helpful. So as I wind down, I do also want to say one of the things that is noticeable and real is COVID reentry syndrome as another example of an anxiety type of disorder that people are experiencing, where being home-based, remote working, you know, for a year and a half, and then now having to go back in the general public where you're seeing, you know, hundreds of people or thousands of people, where you're going to a concert or you're going to a football game or even back to church or even to the grocery store is really traumatic, and it may result in some form or expression of anxiety that could be panic attack, or it could just be hyperventilating. And some people are still preferring to stay home, not let anybody in their home, not go out, you know, which unfortunately sometimes they need to get some help as well. So I'm going to stop there and allow people to ask questions if needed. But I again will say that We Care has taken on mental health as one of its disparate areas that we really want to help the lay community understand that it's okay not to feel well. And certainly what's good for the heart is good for the brain. So things like exercise and socializing and seeking help and helping ourselves is really, really important. And unfortunately, the pandemic has really just changed and impacted life in ways, and it's going to be here for a long time. And what we've known with epidemics and prior pandemics is that the mental health impact is residual for as long as 10 to 15 years beyond the actual event. So this is something that's going to be getting a lot more of attention. We're hoping that there'll be policy put in place to provide more resources. I was actually in a series of meetings in the last 2 weeks where we're strategizing on ways to provide emotional support to faculty, to students, to staff, et cetera, trying to help them navigate through the challenges and certainly the transitioning back to some semblance of life as we once knew it. Not to say normal, but just to getting back in the habit of, in the routine of everyday living. So with that, I'll stop. And I notice we have some questions and comments in the chat. And I'll ask Dr. Austin if you don't mind refereeing some of the Q&A for both Dr. Sneed and I. But thank you everyone for coming this evening. And thanks again for allowing me to have a few minutes to talk to you. You're on mute, Dr. Austin.
Thank you. Thank you both very much, Dr. Sneed and Dr. Hill, for your presentations. I'm here the great majority of the time, and every time I learn something new. So thank you so much. I'm just going to share, many of you have already seen the chat dialogue that went on between Mr. Williams and Dr. Sneed. Very, very important there, because Mr. Williams asked if we had data on COVID-19 for Hillsborough and Pinellas County. And Dr. Sneed, of course, responded that, yeah, we do, but of course, not as much as we had previously. And Mr. Williams, of course, very poignantly reminded us that it is important that we get local data specifically for African Americans. And one of the issues that he presented there was that the national numbers tend to have a higher population of white males. And then Dr. Sneed went on to, you know, tell us what the current positive percentage is. And unfortunately, he mentioned that the rates are going in the wrong direction. And so that's something that we have to be very concerned about. And so Mr. Montgomery's question, are we aware of what's going on with the COVID-19 infections in China?
Yeah, absolutely. Mr. Montgomery, that's a great question. There are two things happening in China, and maybe even a third, but I'll address the first two. Number one, Omicron and very likely BA2, but there are now about 5 or 6 different variants of Omicron, just to be very clear. But over in Shanghai, they've had a very significant outbreak of Omicron. In my estimation, it's beginning to take on, you all may recall that we had SARS, the original SARS. So we call this SARS-CoV-2, or SARS-CoV-2 is what emerged in 2019. The original SARS back in 2002, 2003, one of the highlights of that particular virus was the fact that it was much more resilient than the current variant, and it was able to circulate all the way through air handling inside of buildings. So you could be living in one apartment and you could infect people in the other apartment. That was a hallmark of the original.
Mm.
I'm beginning to wonder if we're seeing components of that, because the living situations in Shanghai find people in very, very close and very confined quarters living with each other. And so number one, they're dealing with the Omicron variant. Number two, their vaccine that they began using, quite honestly, was far inferior to what we have here in the United States. And so they never really got above 60 or 65% efficacy with any of their vaccines, and they have 2. And also they did not vaccinate as many people as we probably had been left to believe that a communist country would be able to do. So now they're dealing with a combination of having an inferior vaccine with the most transmissible form of the variant of SARS-CoV-2 so far. And so when you couple all of that together, now they have in China, they maintain having a 0 tolerance for the for people getting infected. They want, if you get infected, they want the virus to die within you. And so they don't, they will shut everything down and not give you the opportunity to transmit it to other people. But I'm really going to be paying attention. I have not heard the reports yet, but it just appears to me that the internal circulation of the Omicron variant in China right now may indicate that it's spreading indoors at a higher rate than we probably would have anticipated. So I hope that kind of answers that question a little bit.
All right, was that sufficient, Mr. Montgomery? That's what you were getting at?
And please, I mean, we don't have a very large group, so if we want to dialogue back and forth, Dr. Hill and I, we welcome that. But yeah, did I answer the question for you, Mr. Williams? Oh no, that was Mr. Montgomery. I'm sorry.
Mm-hmm.
Yes, thank you.
Great. And then Mr. Williams also asked us about whether or not we provided this information to the NAACP.
Which information are you referring to exactly?
This one.
We have done programs with NAACP in the past. We have not done one recently, but Dr. Austin, Dr. Austin, I don't know if you saw, but I picked out the dates.
Yes.
And I was very intentional because that's about my projection for about the last component of being able to do anything in person safely. Mm-hmm. Okay, I hope I'm wrong. I always want to be wrong, by the way. But if I'm not wrong, I'm thinking, we might get that far, and then, if the past predicts the future, here in Florida, when we get to the summertime, that's when we have found spikes that have occurred, typically because we begin to run people indoors a lot more. We're trying to get out of the sun, we're getting into air conditioning, and then in the summertime, we've had terrible spikes. And so, but having said that, I would love if we can get somebody from the NAACP and other some very similar organizations to come to one of our community chats here real soon.
Mr. Williams, we'll make sure that you and they know particularly about the in-person meetings that we'll be having, as long as we can.
Yeah, and Mr. Williams, if you hear about it, feel free to tell NAACP or anybody else you think that may need to come. Let me just share something very quickly. And this is for both Mr. Montgomery and Mr. Williams. You know, one thing that we want to accomplish right now is helping people understand what impact the virus can have on your body once you become infected, and the true benefit of being vaccinated, both before you come into contact with the virus, and then even after. And I skipped over it very quickly because I really wanted to get to the Q&A and really wanted Dr. Hill to share very important information. But we have to better, I'm beginning to even more than ever, understand that once that virus attaches on to your body internally, that after it attaches on, there's very little defense your body has at that point. And the only defense you really have is, number one, if you've been vaccinated. Now, for people who were previously infected, and we'll come back to that in a minute, but you also have a measure of protection if you've been vaccinated or had previous infection. However, if you had previous infection without being vaccinated, there's always going to be that potential for the long COVID symptoms. That's why I don't want anyone to get infected. But if you've been vaccinated and you come into contact with it, even if you have a breakthrough, we are now proving over and over and over again exponentially that we're going to protect your organs, and your opportunity of either hospitalization, death, or even long COVID is much lower. And so we have to really begin to help people understand the true benefit of what it means to get vaccinated. And I'll come back to that comment in a moment.
Great. Thank you, Dr. Steve. We have a question here from Mr. Flood, a very interesting question. Do you think that the media controls how we react to COVID? And by not broadcasting about it as much as before, has everyone putting their guard down?
Dr. Hill, I'm going to let you take the first crack at that one, and then I'll follow behind you.
Yes, and some of it I think is really to try to control the emotions. So all of the anxiety disorders and things that I kind of talked about, that is a non-pharmacological approach, because we do know there was a lot of overkill. And unfortunately, with the help of social media, there ended up being a lot of misinformation. And early in the pandemic, we had everybody an expert and individuals who were in decision-making positions who were unfortunately inappropriately politicizing what's going on. So right now, it's not necessarily that things are much better. It's just that, we are getting more and more people vaccinated. And so I do think we need to continue to be on guard and not forget that it's still important to mask up, still important to some degree to make sure we're distancing ourselves and mindful of being in situations where you're exposed to these super spreaders. I was just sharing with the dean how I experienced COVID anxiety syndrome because I wanted to see New Edition and I wanted to see Jodeci and I wanted to see Charlie Wilson, but there were also probably about 80 to 100,000 other folk who wanted to see them. And so just trying to get inside the arena was just mind-boggling because I hadn't been around that many people in a long time. And so, yeah, I think some of it is designed to try to control the emotion. Dr. Sneed, what do you think?
Yeah, absolutely. We have to keep in mind that the aftermath, and I think that's why it's so important to have Dr. Hill talk about the mental health aspect. The aftermath of what we're finding is that the mental health of our children and people. I mean, Dr. Hill just said it beautifully. I mean, she's a very, very young 30-year-old trying to go see New Edition, and even she experienced a bit of anxiety being around that many people. So I do think, but also what we have encountered is that people hear what they want to hear when they want to hear it. And the moment that people heard that rates were dropping, people were dropping the mask. When people heard that Omicron wasn't as deadly, they didn't feel like they needed to go get vaccinated. And then, as I showed the data earlier, and I do apologize, I know it went through it pretty quickly, but we had some of the highest hospitalization rates ever when Omicron hit, even though it allegedly was not as deadly or as dangerous as Delta, which in my estimation is still the most dangerous version of what we've encountered so far. So I think there's a combination of all of that together, and that's why Dr. Hill and Dr. Austin and myself and Mr. Green, we're committed that as long as we can, we're going to continue to talk about this with as many people as we can, because we need people to be aware. We need people to not let their guard down, but more importantly, and I saw another question here about, it was from Mr. Montgomery again. It was reported we are expecting a surge in the fall. Will this be a new variant or one we have already encountered? Mr. Montgomery, I'm not here to scare you. I'm not here to scare anybody, but I'm here to tell you the truth. Okay, and I'm talking with my group. I'm talking with my little tribe of people now, of virologists. What we encountered, we are in April now. What we already knew back at the end of January and early February, we have now uncovered that this particular coronavirus, it is now living in deer populations. It's now living in mice populations. It was already living in bat populations. And so we call these reservoirs, okay, just like a big reservoir of water. And we also understand that if you have an individual that could be in a location, for example, in South Africa, that's living in a particular village of people who have HIV, okay? And so now HIV is not AIDS, but HIV does mean that your immune system is compromised. And so we have found people that get infected and the virus will cycle through their body over and over and over again. And then by the time they go and infect other people, that's how we get all those mutations out there. And so we understand it's probably going to be another, it will not be the same variant. It's a guarantee it will not be the same variant. There's no guarantee that it's going to weaken. Many people feel like it's going to weaken automatically. Don't anticipate that. But the saving grace here, that's why we're talking to people, is that if we identify a very dangerous version of this particular virus and now others, we will be able to match a vaccine to that particular variant that will give you, again, 90 and 95% protection against the worst of whatever the worst variant will be in the fall or winter and early spring of next year. So Mr. Montgomery, you're asking a very important question. Again, I hope I'm wrong. And what I'm really hoping, we already know what's going to happen. As a matter of fact, we already found it. We have found more dangerous versions, but the fact is we found it early before it had a chance to get out. And I'm hoping that through enhanced surveillance that we will have much more opportunity, but we have got to educate our communities a little bit higher, a little bit harder, because Black people, once again, Black and brown people have been the absolute most affected groups. Even during Omicron, it touched my heart in a very passionate way that African Americans were the ones that were being infected and hospitalized at the highest rates. Even though disproportionately, we had already taken the biggest brunt of all of the infection beginning way back in March of 2020. So when do we get a chance to live a good life? And so Mr. Montgomery, you're asking a critical question. I know it's a long answer, but I want everyone to hear the very credible information about what that means and why we need people to improve their health. If you have diabetes, we need you to get it under control. If you have high blood pressure, we need you to get it under control. We need to get out and physically walk. We need to eat better. I mean, I have included more fruits and vegetables in my diet over the past 3 months than I had over the past 3 years. And it's all because I know that something worse is coming.
Dr. Hill, okay, go ahead.
Yeah, I just wanted to kind of add to what Dr. Sneed said about the importance of self-care at this moment. And what I really want to add to it is the importance of screenings, because unfortunately, the pandemic when we transitioned over to telehealth and stuff, people just stopped getting the screenings, particularly a lot of the cancer screening. And what we have found is people are discovering that they have cancer much later. Oh, am I still on? Okay. Much later and in more advanced stages. And they may be beyond the point of return as it relates to treatment. So we do want to encourage people to get the proper screenings and the wellness checks, but definitely managing those chronic disorders is crucial. And then my other mention is that we have to remember that, especially in the realm of mental health, when adults are affected, the children are affected directly or indirectly, and they have a greater chance at mental health issues, when adults aren't seeking appropriate treatment. Because if we're not healthy, we can't be good for anybody else. And so we have to take care of our physical health as well as our mental health and our spiritual health. And so it needs to be, holistic in that regard.
Dr. Sneed, one of the things that I want to say to you kind of humorously is that you know my boss, Lo Berry.
Yeah.
And one of the things that Lo Berry does is she keeps up with everything that you say, all your predictions and prophecies, as she will say. And one of the things that she has said, and I've heard her say it a number of times, that she's keeping up, she said, he hasn't been wrong yet. And so, but we know that that you're always looking at the data, that you're very diligent about all of that. So we really appreciate that greatly in the community. So Mr. Flood again asked Dr. Sneed and Dr. Hill, are we ever fully recovered from COVID? Or can we just expect that there are always going to be some lasting effects?
Yeah, I'll take the first stab at that. There are some people that get infected with COVID and they have no problem at all. I mean, from the time they were infected, even if they got a little bit symptomatic, the moment it's gone, is gone. There are other people that were mildly infected that wound up having, I know people who have been infected from 2 years ago that are still affected today. And so I think we're uncovering now some of the genetics behind individuals, why some people may become more susceptible to long COVID than others. That's number one. Number two, and Mr. Flood, this is part of the critical information. Again, I know I went through it pretty quickly, but I'm glad we're talking about it now. Once that virus, once it gets into one of your internal organs and it replicates at this massively high rate, part of that replication can be very damaging to the tissues of that organ. And depending on the level of damage and the location of the damage in that particular organ may dictate whether or not you have a very long-term effect or whether you barely experience anything at all. And at this current moment, when it comes down to millions and hundreds of millions and even billions of people, we have yet to be able to uncover who's going to fall into what category. And so your question really does run the full spectrum of you may never have a problem again, or you may get mildly infected, get over it, have no problem, and then wake up a month or two later only to find that you have this massively big problem from long COVID. And I've seen the full spectrum, even in my own patient population. So Dr. Hill, I don't know if you want to add anything on, especially from a behavioral or mental health standpoint, but clearly we know that the full spectrum of nothing may happen all the way to, even if you get over it fully, it may come back because the damage to that particular organ has now manifest even months down the road.
And, Dr. Steen, I think you covered it, very eloquently, that everybody's individual things that they bring to the table, hypertension, diabetes, or not, certainly impacts what experience they're going to have with the virus. I think also if they're vaccinated, they may have very mild symptoms, which subsequently may equate to very mild residual effects. The type of variant also sometimes brings on different types of symptoms because it may have a greater propensity to actually bind to receptors and make it to the brain versus the kidney versus the liver. But again, it's all so individualized. So a lot of this mental health stuff is certainly influenced by external factors as much as it is by internal individual factors. And so that's all, I kind of would add to that. So I kept seeing the question too about, do we need to look forward to continuing to get vaccinations? And I think, Dr. Sneed, what is your thought?
Yeah. There's two parts to it. Number one, for individuals right now who are immunocompromised, okay, or for individuals that fall into a particularly high risk category, my recommendation would be that you get vaccinated. Now, for people that fall into a moderate to low risk category, and if the infection rate is pretty low in your area, right now, my recommendation is that you wait, because again, if we don't have to, there's a really technical term I'm trying to avoid using, but if we don't have to stimulate your immune system more than we need to, then we just don't need to. However, when people are trying to make a determination between getting vaccinated or unvaccinated, I can assure you that the virus is always going to be more potentially dangerous than the vaccine. Inside of that virus, okay, so I'm making my little ball here. I'm looking on the camera. And the inside, there's a little RNA strand that Dr. Hill just alluded to that kind of dictates what it will do to your body. None of the vaccines have that little RNA strand in it. They just don't have it. And so any side effect that you may get from the vaccine can be precipitated in the same way, if not worse, by the actual virus. We have to understand that, it doesn't go both ways. So if, there's a lot of things that can happen to you that the virus can do to you that the vaccine can never do to you. But there are things about the vaccine that if you experience it, it's quite possible that you are going to experience the very same thing should you come into contact, because what these vaccines are giving are the equivalent of those little spike proteins on the outside, nothing more. And they just help your body identify, if I see that little spike protein again, it's kind of like, you know what? If you saw somebody break into your neighbor's house and they had on a certain kind of hat, if you saw that hat again, you're like, wait a minute, I've seen that hat before. Don't come around my house. That's kind of what your antibodies are doing. If they, we're training your immune system to identify that virus. And if the virus does get into your body, the antibodies are going to say, wait a minute, I've seen you before, and now I'm coming to get you before you cause damage. So so right now, I'm just going to say it depends on who you are and where you are if you need to get the fourth shot. I personally cannot blanketly recommend it for any and everybody at this current time.
Okay, Ms. Evercon, does that answer the question that you asked?
Pardon me?
I was just asking Cynthia Evercon, because she's the person that asked about the fourth
okay.
booster. I was just asking if you had answered everything that she needs to know when she asked about that fourth booster.
I want to kind of say something real quick. I want to say it because I don't want to type it all in that damn box.
That's all right.
Yeah, no, we want the conversation.
Get it in. You just mentioned on a graph. There's a problem with African American community. Okay, we have never fared well when it comes to health in us. There is a distrust. So I don't care how much you put the science or how bad things are. If you don't address the trust, then you're not going to address us taking the vaccine. And I don't know how many people that were in the clinical trials look like us.
A lot.
So, but we don't know that, right? We're
Yeah.
because right now you said a lot. That could be anything. I don't know what that means,
Yeah,
percentage
yeah.
wise. You know?
Yeah, you know what, during the earliest phases of our presentations, I used to show those numbers.
You did.
As a matter of fact, I'm glad, this is a great point. I'm going to make 2 quick points. Number one, we have never in the history of not only vaccines, but probably other mainstream medications, we've never had more people involved in clinical research around one disease state than we had for the vaccines for COVID-19. I'm talking, we had 45,000 people in the Pfizer study. We had another 30,000 people in the Moderna study. Johnson & Johnson had about 70,000 people. We picked up another 35,000 people in the Novavax study. And so, in the AstraZeneca study, I'm not sure how many we had here, but they had another 30,000 in that study. And so when we looked at the data for Moderna and Pfizer, roughly a third of the people in those trials were people of color. And we've never had that high of an immersion of African Americans and Latinos that were participating in almost any clinical research. So I think you're addressing a great point about the trust. But the thing that I found to be particularly effective right in the middle of the pandemic, when our We Care and Reach Up team was going out and talking to people, is that if you take the chance and you lose, okay? Because listen, we have watched so many Black people get infected and die. We watched our family members die. We watched our family members get infected and go in the hospital. We watched all of this happen, and then still turned around and said, I'm not going to you're not going to vaccinate me. And so at the end of the day, when you strip everything else away, the disproportionate impact on African Americans is bound in our ability to wind up hearing the truth and then trusting the trusted messenger. And so that's why I've been very clear. We are going to continue coming out into our communities all summer long. We're not going to stop in an effort to try and build a trust, because I feel that in the fall, if we need it, Dr. Hill and Dr. Austin and I, we cannot spend that same level of energy just trying to build trust. We're going to spend the energy to build the trust now, so that when you need to hear some life-saving information in the fall, you'll say, you know what? I know Dr. Sneed, I know Dr. Hill, I know Dr. Austin, I know We Care, I know Reach Up, and I know they want me to live. So that's why, so you're bringing up some of the most critical points that are happening all over the country. And Dr. Hill and I were walking down the hallway, was that yesterday? And I told her, you know, people, we've dropped our guard so quickly and rapidly that, I mean, we're going to have to do a much better job of regaining that level of trust. But tonight, there's about what, 15 of us on here? We need to be able to, we have to magnify this by about 100,000 people.
But I think, and you see 2 symbols on top over me.
Mhm.
And it's funny because I'm also American Legion, right? And each
Yeah.
of them have a different freaking mentality. I'm telling you.
Mhm.
The American Legion, they don't wear the mask. They do not wear the mask. And all of them have COVID. Then there's NAACP, and then there's veterans. When you talk about NAACP, you're sitting there making COVID seem so dangerous when they're face people with bullets or whatever. They're facing stuff that's like, I can see that guy, you know, the constant. I'm just telling you with the backdrop. When you guys finally come talk NAACP, you got to talk like you're in their neighborhood, not talk like, oh well, look how bad COVID is. We'll say, well, you know what? Just yesterday, my brother or cousin just got shot, and 2 of them are in the hospital. That to me is the most dangerous to me than the COVID.
Yeah.
I'm just saying.
You know what? Let me bring up. No, this is the dialogue we need to have, especially with people present. Let me share another point to you. You know, when the Delta variant first emerged, when it first came out, and we said, "Uh-oh," and it swept through the southeast of America, and it hit Mississippi, Alabama, Louisiana, Georgia, and then it crept up into the Midwest, into the Dakotas, and all of a sudden, the highest death rates were not African Americans anymore, or the highest numbers. Because now all of a sudden, large numbers of Caucasians who had not been vaccinated, that had the very same mentality that you just described, they were the ones getting infected with Delta. And then all of a sudden it began to exploit the very same cardiovascular nature in many of those communities, even though now it was primarily white communities and not just Black communities. And so the thing that we have tried to share with people is that the virus, it doesn't care about your color, your race, it doesn't care about your political background. The virus doesn't know. And I'm going to ask you, you don't have to answer the question, because you may not want people on here to know. If you're in a relationship, I don't know if you're married or not, you may not want your wife to know. But I have challenged people. I said, if you walked into a large cigar bar and you were going to walk from one side of that cigar bar to the other, and it was going to take you about 5 minutes to get through, and there's smoke in the air, do you think you're going to get from one side to the other without inhaling cigar smoke? You're not. You are going to inhale some cigar smoke. Well, for Dr. Hill and I, that virus is no different, except you can't see it, you can't smell it, but if you're indoors, it's there. And you're going to inhale it, and then the moment it gets in, it's going to go and infect all those organs I showed earlier. So I think you're right when people are saying, I can see somebody trying to shoot and kill me, bullets flying. I went to Vietnam. When we hear people say, hey, I have a strong immune system, let me talk about that for 30 seconds. This particular virus has evolved. This is evolution. It defeats our early alert immune system. So you may have a strong immune system, but you know what? When it infects you, your body, it has learned to trick your body. Your body doesn't even know it got infected. It actually shuts down and deactivates part of your immune system. That's evolution. And your immune system, as a human being, it was defeated before you got infected. So I'm agreeing with you. Everything you said, I completely agree. You haven't said an incorrect word that I disagree with right now. But I'm just presenting the other side of the argument about why I'm so passionate about it. Because at the end of the day, if we continue to have to say, well, I'm not going to trust something that can save my life, that means that we just become negatively impacted and affected with an A, affected, not infected, not just infected, but we become negatively affected by a virus. It's not programmed for Black people. It's just programmed in that, you know what? I can't even say it's programmed for human beings. It's just programmed for mammals, deer, mice, bats, anteaters, gorillas. I talked to some researchers from Washington State. We had a big chuckle. They had 8 gorillas get infected down at the San Diego Zoo from the zookeeper. True story. Dr. Hill, how in the world do you get close enough to the gorilla for you to be able to infect the gorilla?
I don't know.
I don't want to think about that either.
Hey, when you figure that one out, let me know.
That's crazy. I wanted to show a picture. I think, sometimes pictures, tell a story that kind of helps people understand. I saw Mr. Montgomery ask the question, about how does the virus affect the brain.
Yes.
And what, so, when we go back to why we're wearing masks, it's because this virus gets in the nose area and that olfactory area. So this is the nose, and those receptors are right there at the front door. And it attaches on and it kind of moves its way through all the hairy parts and everything. But there's some nerves that actually serve as a highway for the virus to actually get into the brain. And so that's why people lose their smell and or lose their taste, because those nerves are also located, near the nerves modulate taste. So as Dr. Sneed was describing, people who have diabetes and hypertension and all of that, they end up setting off processes because the immune system, like he said, the virus goes into stealth mode. If we use an analogy that veterans would understand, it goes into stealth mode. And before the body can recognize it's there, it's already gotten across some of our primary defenses through the skin, and it sets off. The immune system is kind of like, I think something's there, but I can't see. And so it confuses the immune system, and it goes into this cytokine storm where we have all of these inflammatory processes magnified. And that's what he was talking about. So then what happens is you get a lot of cells that would normally fight off the infection overacting. They're super excited. They're ready to party. The problem is the virus has already replicated and it started attaching to cells or those ACE2 receptors in any other organ. So initially we kept hearing, oh, everybody was needing lung transplants, they were needing ventilators, and that's because we only have a few receptors, ACE receptors in the actual lungs, but the surface area that represents is so large that it was causing lung failure. But we have had, as Dr. Sneed was describing, kidney failure, liver failure, people needing transplants and all of these organs because we have a large number of them, of these receptors all over the body. So one of the challenges, Dr. Sneed likes to tell us all the time that it is a cardiac virus and not a respiratory virus, because actually we have drugs that modulate that same receptor and control our blood pressure. And so that's why you were hearing about people having clots and strokes and all of this kind of stuff. So Mr. Montgomery, to answer your question, the virus is not so much getting in the brain and modulating brain activity, but it's setting off inflammatory processes in the brain that then impact stuff like mood and all. Now, there is some genetic data showing connections, that also show abnormalities where people are going to be a little bit more susceptible to Alzheimer's disease and some of our memory processes. And that's because these inflammatory processes kind of set off cells that look like these microglia, which are just small cells in the brain that actually affect our learning center, which is the hippocampus or the brainstem area. And these actually, if you see the functions, the lower brainstem modulates respiration, modulates heart function, as well as sleep. So it makes sense why people would have complications, from the virus in those areas. And the same applies as far as the brain. We have issues with learning and memory. And then the mood stuff is all just a byproduct of it. So it's not modulating like the neurotransmitters and neurochemicals I was describing that are deficient, that we see oftentimes in mental illness. But what we do see is that inflammation, those inflammatory processes, as they take place in the brain, it does then impact the functions that the brain would normally manage. So I don't know if that kind of helps answer your question.
Dr. Hill, I'm going to come right behind you. I'm going to show another, oh goodness, which one is it?
Mr. Williams said we need to send him a CE certificate for this.
I heard that. I heard that. Let me show you this. So so we actually went and found that when people were talking about some of this brain fog, that we actually found that the virus had climbed its way into the brain was actually reducing the gray matter in the brain. Now, it doesn't happen for everybody, and that's where Dr. Hill was saying, you know, we understand that there may be genetic components, there are other things that are happening. But, you know, I think one of the main reasons that we are, you know, we're continuing to share this information is because we shouldn't be the, you know, we have a solution. And it may not be 100% solution, but it's better than the alternative for all the things that can potentially happen to you. You know, for all the men on here tonight, you know, we got to a point that if you were between a certain age range from 25 to 50, 49, 1 in 5 men were now reporting some level of erectile dysfunction. And the overwhelming majority of them were unvaccinated. And because it can go through and it can actually attach on to the male reproductive organs. So, you know, we understand the mistrust that people have, but the mistrust doesn't override the virus. The virus doesn't care if you trust it or not. It's gonna, if you get it, you know, I mean, there's some bad things that can happen. Let's see. How are we doing on questions, Dr. Austin? I've been trying to scroll through a little bit too.
I've been scrolling through. I think that we got.
Because you know what? Everybody latched on to Dr. Hill saying, "Hey, I went to see New Edition."
Yes. Yes.
That was a great concept.
And I do like the fact that someone reminded me that, you know, that the New Edition folks are not new anymore.
Nope.
They are now senior citizens.
They all have risk factors for COVID infection, believe me.
They are now senior citizens. But Dr. Hill and Dr. Sneed, one of the things that I like to share, many of you know that we reach up, a good deal of the work we do is in maternal and child health. And one of the things that we saw 6 to 8 months ago were articles about the fact that about 60,000 children in the United States had lost their primary caretaker to COVID. And so I know the numbers are greater even now. So that's one of the things that, you know, we have to think about as people who work with children. And that is, you know, how we're going to be able, as you were talking so eloquently about, Dr. Hill, how we're going to deal with the emotional, the trauma of these children having lost a primary caretaker, parent or grandparent to COVID. And as you would know, and I don't have to say it, the great majority of those children are, number one, African American, and number two, Latino.
Yeah.
You know, Dr. Austin, and you, I'm gonna share the other story. I think I'm gonna share it everywhere. But you know, you bring up such a great point. You know, if you can't do it for yourself, who will you do it for?
Yes. Yes.
You know, if you can't, you know, if you can't do it for yourself, do you have another reason in your life that you should do it? That you should try to protect yourself. So, I just want to share this quick story, Mr. Williams. And this particular story is not an African American family. But when I was talking to some of the people and we were having our moments to kind of let it all out, you know, when I was talking to one of my physician colleagues over at Tampa General Hospital, we were talking about, I'm going to say a 31-year-old man. They had a 20-something-year-old wife, and they had 2 children, 2 little girls. Both were old enough to walk, but they were young. And the man refused to get, he's now sick in the hospital. He had refused to get vaccinated. Okay. He died. Now, I'm going to be I know we're being recorded, but I'm going to be a little bit more direct than I normally am because I feel comfortable with I'm a Kappa, but y'all have welcomed a Kappa into your presence tonight. Okay. With my Phi Beta Sigma brothers, I love dearly. When I first heard that story, but then read stories all around the country where it has been replicated over and over and over again, what that person chose to do, they made a choice. They made a choice to not be available as a father to help their children not only grow up, but hopefully grow up one day and become productive members of society where he can walk them down the aisle. They get married. He forfeited that opportunity. Now here's the more graphic part. What he really chose to do was to take the woman that he loved and probably thrust her into the arms of another man. Because she has 2 young children, and somebody's probably going to be there to comfort her. And that was a choice he made. And that choice has been replicated around this country over and over and over and over again. When I show these graphs of people hospitalized, unvaccinated, and then the people who are vaccinated, there's barely any line. We know the solution. We understand what to do. We need to wear masks more. So, that's why we're going to work hard to try and build trust, to try and let people know how much we care. I want you to go out and talk to people that you care about. I want to empower all of you to go out and have the conversation. I have a lifetime of stories. I mean, I've outlined a book that I intend to write. I have a lifetime of stories. I could sit here and tell you that each one of them has broken my heart. And this is the honest to God truth. African-American couple, I'm not going to say from where, both had just retired, bought a house in a different part of from where they live. They both got infected before they left when they had a moving van. By the time they got and drove to the destination, the woman was coughing. She was sick. He was coughing too. She went in the hospital. They drove up to their new house and were too weak to start unloading. Had to go to the hospital. She died. Now they've been saving their entire life. They've been planning. They found a house at a brand new location. They're going to live the next part of their life. Oh, they were planning, had a house for the grandchildren to come. And they were unvaccinated. I mean, I can tell these stories all night. Dr. Hill, I'm sure she has her own stories, I know. And all we want, we deserve the chance to live. That's all I'm saying. We deserve as much a chance to live as anybody else. And when Delta hit and we saw white America become so negatively impacted, I couldn't understand it then. And I don't understand it now, even for that population across the country. I don't want anyone to be negatively impacted, but I know that if we only make up 13% of the population across the country, and we have a little virus going around chipping away at that, that means all we're doing is diminishing our impact and our existence to be able to live a full life. And Dr. Austin, I had, you talk about you learned something new from me. I had no clue the number was 60,000. That's a startling number. And we know that's low. So I think this is a great conversation about, we need to go out and that's why, Dr. Hill and I, look, we're only going to talk to you for about 15 minutes apiece, but we want to have real conversation with real people and answer real questions so that you can go out and say, look, I can't remember that dude's name. He had on a green scrub top. It was Dr. somebody. I think it was Dr. Smith. I know it began with an S. But he told me something that made me reevaluate for what may happen in the fall or what may happen in the future. I mean, we deserve to live. Dr. Hill, can I preach anymore?
I was about to say, go ahead and preach. Go ahead and preach.
I mean, do you want to add on to the sermon?
No, I think you're doing fine. You're doing fine. I think we kind of addressed most of the questions. for the most part.
Yep, I think we have, and I know it's coming up on 9 o'clock, and
Mhm.
I'm gonna have to answer to my real boss here in a minute. Okay.
But I would like to say, Dr. Sneed, as some closing notes, we do appreciate everyone coming and sharing this evening. And Mr. Montgomery, thank you so much for
Yeah, thank
inviting
you.
us again
Thank you,
to
Mr.
kind of give
Montgomery.
everybody an update. Thank you so much. As one of our ambassadors, we just so appreciate you and are just grateful for you. And we want to invite all of you into our We Care family. So you all will be hearing more from us. We'll be sending out information on upcoming programs. We also would like for you to reach out to us if you have any questions. And we want to invite you to check out our We Care video library, which shows a lot of old recordings of things that we've talked about, as Dr. Sneed commented on, since the start of the pandemic. So you can appreciate things in different fashions regarding different topics. We are currently helping recruit for a study related to cancer screening. So if you get information about that, we hope you would consider. But we also invite you to learn more about how important it is that we have individuals that look like you participating in studies, so that when vaccines and other treatments come out, we don't have to worry about whether or not it'll work in us. And we also hope that you would invite other people to come so we can tear down those barriers that are impacting people's inability to trust the health system and some of the things we're seeing on the media. So with that, we just thank you. We'll stay on a few minutes. So if you want to copy information out of the chat, you can. And/or if you want us to email it to you, both Dr. Austin and my email are in the chat, and we'll be glad to get the information to you. So thank you again. We ask that you stay well. Please, if you know someone who's not vaccinated, encourage them to get vaccinated, but everybody wear your masks and continue to remain safe. So with that, thank you so much again, and we hope to see you sometime soon. So Mr. Montgomery.
Mr. Montgomery, we deserve to live, Mr. Montgomery.
Absolutely, we sure do. And I want to say thank you once again to everyone at We Care, as well as Reach Up, for everything that you all continue to do for our community. I also want to give a shout out to my Humana family, Miss Cynthia Everett Khan. I really appreciate you for joining as well. You know, it's a lot of information that we took in, but it's very vital that we actually spread it out to our communities. So thank you everyone for attending, and for my Sigma brothers, go Mob. And I'm sorry, I didn't mention that we know Dr. Kevin Sneed said that he's also a Kappa, but Dr. Angela Hill is also a member of Delta Sigma Theta. And so, you know, we love the love. Yeah. And Dr. Austin, if you're not a part of anything, you know, we know some sisters.
She's a Delta in spirit.
Oh, okay.
Well, that claim came out real quick.
She's been working on her community service hours.
Well, we absolutely love it. Thank you all, and I hope everyone has a great night and a great rest of their week.
Okay, good night.